All right, good morning, and welcome to the Department of Internal Medicine Grand Rounds. Our speaker today is Dr. Joseph Elmunzer, Associate Professor from the Division of Gastroenterology, and Peter B. Cotton Endowed Chair in Endoscopic Innovation. Dr. Elmunzer received his undergraduate education and medical degree from the University of Miami. He completed his internal medicine residency at the University of Texas Southwestern, and then completed his fellowship in gastroenterology and endoscopy at the University of Michigan. He also completed a special fellowship in developmental endoscopy and notes research, or natural orifice transluminal endoscopic surgery, at Case Medical Center in Cleveland, Ohio. Prior to coming to MUSC, Dr. Elmunzer was on staff at the University of Michigan for 6 years. He moved to MUSC this summer in July 2014 to continue his practice and research in advanced therapeutic endoscopy. He is very active in research and has multiple current grants, including 2 which are focused on improving the safety of ERCP. He is a very prolific author and has over 55 peer-reviewed publications, including video publications. He has delivered multiple presentations on advanced endoscopy all throughout the country, and his presentation today is titled Game-Changing Advances in Therapeutic GI Endoscopy. Please join me in welcoming Dr. Elmunzer.
All right. Thank you, Skip, for that kind introduction, and thanks, Don, for inviting me to be here. I am very honored and happy to be at MUSC, especially in December, since I did move from Ann Arbor, Michigan. So I became a GI fellow in 2005, and since then I think we've seen some really tremendous advances in therapeutic GI endoscopy that have fundamentally changed the way we approach a multitude of clinical problems. In the next hour, my goal is to introduce you and expose you to several of these recent developments that you may not be aware of but can be very helpful to your patients. More than that, though, I'm hoping these advances will inspire all of us in our clinical practices and in our research to continually push the envelope toward positively changing the game for our patients. So I have no conflicts of interest to disclose. So as I thought about what it means for a medical advance to be game-changing, I think that concept is best captured by the business term disruptive innovation, or what some people call a disruptive technology. So disruptive innovation has novel attributes that allow it to prosper within a marketplace and then ultimately displace a former technology. And this eventually leads to a fundamental change in the market, or in the case of healthcare, how we approach a clinical problem or scenario. Now, the psychology and the market forces that impact clinical medicine are naturally more complex because we're dealing with human lives. And so in this context, a disruptive innovation can actually become complementary for some time with existing technologies and options, but will still fundamentally change the way we think about problems. Now, this is in contrast to a sustaining innovation, which improves sometimes significantly the way things are done, but doesn't necessarily change the game. So before discussing disruptive innovations in therapeutic endoscopy, which is sort of my area of interest and my focus, I think it's important to acknowledge that we've seen some really important disruptive innovations in diagnostic endoscopy as well. So video capsule endoscopy and balloon-assisted enteroscopy have basically allowed us to conquer what had traditionally been our final frontier, which is the small intestine. And I think we're on the brink of potentially really important disruptive innovations in advanced GI imaging in things like in vivo microscopy and molecular imaging and enhanced endosonography and so forth. And I think it's important to realize that concurrent to all these disruptive innovations have been ongoing sustaining innovations in our fully mature therapeutic platforms, innovations in ERCP and intraductal endoscopy, in enteral stenting, and in endoluminal incisional therapies, to name a few examples. So as I mentioned, I think arguably the most important disruptive innovation in modern endoscopy has been the advent of the video capsule endoscope, which subsequently led to the development of balloon-assisted enteroscopy, which now allow us very robust diagnostic and therapeutic capabilities throughout the GI tract, and I think, or throughout the small intestine, and I think we can look forward to additional innovations in the upcoming years, like these remote-controlled capsules with fins and stabilizing tentacles, and even capsules that are going to have robust therapeutic capabilities that can be controlled remotely by the physician, maybe even from home. And as I mentioned, I think we've seen some very impressive sustaining innovations in therapeutic endoscopy. So the top left panel is a case of cholangioscopy, or intraductal endoscopy. This is a patient with symptomatic gallstones who has cirrhosis, but he's too sick to undergo a cholecystectomy. So the goal of this procedure is to place a stent into his gallbladder. But we try a standard ERCP and we weren't able to opacify or identify the cystic takeoff. So what we've done is we've introduced a camera into the bile duct, what's known as cholangioscopy, to directly identify the cystic duct. And this is the opening right here. And then under direct visualization, we can selectively advance a wire through the cystic duct into the gallbladder, over which we can place a stent. The top right panel is a case of choledocholithiasis, so stones in the bile duct, but the LFTs didn't improve after removing those stones. So this is a second look ERCP about a week later. And as we approach the papilla, we see this thick mucus substance coming out of it, which is abnormal. Here we're advancing a standard upper endoscope through the biliary orifice into this dilated bile duct, where we encounter more of this thick mucin, but we also see this frondy multifocal mass in the right hepatic duct that we can biopsy using a standard GI forceps. And so this is true intraductal endoscopy. Now and here we're using an extraction balloon to physically remove that mucin from the intrahepatic ducts, but this turned out to be something called IPMNB, or what was known as biliary papillomatosis, which is a premalignant condition. The bottom left panel is a case of a bile duct stone impacted at the papilla of Vater in a patient with a Billroth 2 reconstruction. So as some of you may know, in patients with a Billroth 2 operation, the papilla is actually a mirror image of its original self. That's its configuration. And so our ERCP tools don't work very well. So what we're doing here is incisional therapy of the papilla using this needle knife device. This is a catheter with a short cutting wire at its tip that can deliver electrosurgical current to incise the papilla and expose an underlying stone. This up here is a stent in the bile duct to direct our incision. But here, as we extend our incision sequentially, we can see that the stone begins to crown a little bit. And then eventually we will extend this incisional sphincterotomy large enough such that this stone can deliver spontaneously from within the bile duct into the lumen of the duodenum. And that's going to happen right here in a second, hopefully. Right, and so this is equally satisfying for patient and endoscopist alike. Right. The bottom right case is another case of incisional therapy. This is a rare condition known as a windsock diverticulum, which is a membrane of tissue that obstructs the lumen of the duodenum. And so we're doing an endoscopic incisional diverticulotomy using that same needle knife device. So we've demarcated the incision plane by placing these endoscopically applied clips. And then what we're doing is we're going to deliver electrosurgical current to literally try to transect this membrane in order to reestablish luminal patency. Initially, we're transecting we're incising from the top down, and then in a second here we're going to change gears and start to incise from the bottom up sequentially, hoping that our incisions meet somewhere in the middle. And then as we get close to completely transecting that membrane, we're going to switch to a standard ERCP device, which is known as a sphinctertome, and deliver a little bit more current to basically transect that membrane, reestablishing luminal patency and saving this patient a potentially large abdominal operation. So with that in mind, let's discuss the game-changing advances in therapeutic endoscopy. And I think these have come in three major areas. Number one is in the endoscopic eradication of GI neoplasms, both in terms of resection techniques and ablative techniques. Number two is the platform that is interventional endoscopic ultrasound. So the endoscopic drainage of extraluminal, mainly pancreatic fluid collections, as well as EUS-guided biliary and pancreatic access and drainage. And number three is the endoscopic closure of GI luminal defects. But I think before fully understanding these advances, I think it's important to understand the phenomenon of NOTES, which is natural orifice transluminal endoscopic surgery. So NOTES represents a paradigm shift in surgical thinking that a skin incision may not be necessary to access a body cavity. Instead, the abdominal cavity or the thoracic cavity can be accessed using a flexible endoscope through an incision in the GI tract. So NOTES has been proposed as a novel surgical platform that will be less invasive and morbid, and certainly cosmetically superior to conventional and even laparoscopic surgery. So this truly represents the paradigm of incisionless surgery. So this is an illustration of a flexible gastroscope that's been introduced through an intentional perforation in the stomach into the peritoneum and subsequently into the pelvis, where it's being used to grasp the fallopian tube to perform an endoscopic tubal ligation. This is an illustration of a scope that's been advanced through the top of the rectum, through the peritoneum to the subhepatic space, where it's being used to perform a cholecystectomy, and the gallbladder specimen can be removed entirely through the anus, avoiding all abdominal incisions. And this is a laparoscopic image of a flexible endoscope that's been introduced into the peritoneum. This is liver up here, through a defect in the anterior stomach wall. So the first clinical case of notes actually occurred in Hyderabad, India in 2002. This is a case of a gentleman with suspected appendicitis who could not undergo an operation because of extensive total body surface area burns. So this is endoscopic footage. The scope has been introduced through the stomach into the peritoneum. And then they're going to identify the appendix. And so this is the appendix right here. And they're going to take down its fatty attachments using a hot biopsy forceps. So this is a standard GI device. It's a forceps that can deliver electrosurgical current, and they're using that to basically transect these fatty attachments. Once they've done that, they're going to use this detachable snare, what's known as a polyloop device, and they're going to cinch it at the base of the appendix to ligate its blood supply. And then they'll use this polypectomy snare, which is a device we use to routinely remove polyps in the colon. They'll cinch that snare around the base of the appendix, and they'll deliver current to basically resect and perform an appendectomy. They're instilling antimicrobial solution into the peritoneum and then aspirating it. And then you can actually see the surgical specimen, which should pop up right here. And they're going to use a standard biopsy forceps to grasp that specimen and then retrieve it through this overtube that's running through the patient's mouth. Now, not to worry that this is a completely normal looking appendix without any evidence of inflammation whatsoever, but nevertheless, I think this case showed the world what was possible using, it's true, this case showed the world what was possible using this novel endosurgical platform. So many potential applications for notes have been proposed in both the chest and the abdomen, and between about 2005 and 2009, there was sort of this mass hysteria, there was notes mania, where innumerable animal experiments were published in both the GI and the surgical literatures. But despite all that early enthusiasm, unfortunately there's been extremely limited uptake of pure notes in human clinical practice. So in 1987, somebody got up to a podium and proposed the laparoscopic cholecystectomy. And within 3 years, 20,000 laparoscopic cholecystectomies have been performed worldwide. And part of the reason for that is that the tools for lap chole were already fairly mature at that time, having been used previously by gynecologists. Unfortunately, the tools for notes are still pretty much in their infancy, and we haven't been able to overcome several of the critical barriers to notes, like truly reliable access site closure and some of the basic mechanical needs in the peritoneum, like triangulation. So over a decade after the first notes case, it still hasn't had any realistic part in clinical practice. Now, I think with additional research and development and technological advances, I think notes will eventually have a niche market, but it certainly has not panned out as a disruptive innovation thus far. Indirectly, though, I think notes has had a major impact on the practice of therapeutic GI endoscopy. So first, it's blurred the lines between minimally invasive surgery and maximally invasive endoscopy. And so psychologically, it allows us as endoscopists to think a little bit more like surgeons and to be confident and comfortable taking on problems that were traditionally relegated to surgery, like treatment of cancer, or like a little bit of confidence working outside the luminal GI tract. In addition, notes has given us a little bit of experience and quote-unquote comfort with perforations of the GI tract. So traditionally, if an endoscopist recognized a perforation, he or she would pull the scope out as quickly as possible, hang antibiotics, call the surgeon, and pray. And now, in large part because of the notes experience, we know that not all perforations require an operation, and in fact the majority can be dealt with endoscopically in real time. So to a therapeutic endoscopist, a perforation is no longer necessarily a complication, but rather an event that occurred during the procedure that was addressed in real time, and often we continue the procedure towards the endoscopic goal after we've treated the perforation in real time. Along these same lines, I think research surrounding the development of access site closure device has led to the discovery of several effective endoscopic closure devices that allow us to treat perforations in real time. So it's no longer absolutely critical to avoid a perforation at all costs, and that allows us to be a little bit more aggressive. And sometimes that aggressiveness, when applied responsibly, is exactly what you need to achieve your endoscopic objective, and so it allows us to be a little bit more effective. Now, it's important to keep in mind that all the procedures I'm going to discuss from here on out were actually proposed and sort of developed prior to notes, but I think their maturation concurrent to the development of notes led them to achieve their maximal clinical potential. So let's switch gears and talk about the endoscopic eradication of GI neoplasms. So endoscopic mucosal resection, or EMR, has been a complete game changer for the management of early esophageal cancer and its precursor, high-grade dysplasia, Barrett's esophagus with high-grade dysplasia. And this is particularly relevant because the incidence of esophageal adenocarcinoma has risen way out of proportion to other malignancies over the last few decades. The traditional gold standard for the treatment of early cancer or high-grade dysplasia has been the transhiatal esophagectomy. And this is, of course, an important and life-saving operation, but it's big-time surgery, right? It requires a large abdominal incision and neck incision. The majority of the esophagus is removed and the stomach is pulled up into the chest. This is associated conservatively with a 30% serious complication rate. On average, patients are in the hospital for a week. It takes them up to 2 months to recover to full activity, and up to a year for patients to adjust to their new plumbing. So clearly in patients with very early lesions in whom the surrounding lymph nodes are perhaps not as critical, a minimally invasive endoscopic approach would be highly beneficial. The problem or the challenge with the treatment of Barrett's esophagus and its complications traditionally had been that the lesion is either flat or minimally nodular. So there's nothing really to grasp onto with a snare. But that obstacle was conceptually overcome by the concept of rubber band ligation followed by snare resection that was proposed in the mid-90s mainly as a novel tool for tissue acquisition within the esophagus. And that concept eventually led to what we now call band EMR. So band EMR is a technique that relies on an endoscopic banding device, which is a device that we use to deploy really tight, small rubber bands around esophageal varices to ligate blood flow. The device is basically a clear cap that can be attached to the tip of the scope that's loaded with rubber bands that can be deployed distally. So the target epithelium can then be suctioned into the banding cap. The band can be deployed distally, and it ends up capturing everything that had previously been within the cap, creating this neopolyp where one didn't previously exist. Then we can close a snare underneath the band and deliver electrosurgical current to transect that target tissue. And as we repeat that sequentially in overlapping fashion, we eventually end up with a wide field resection. So this is an example of a typical band EMR for complicated Barrett's esophagus. I start my approach by injecting a combination of fluid and blue dye into the submucosal space to create a little bit of a safety cushion. Then the target tissue is going to be suctioned into the cap, which is occurring right here. Then we'll deploy the band to create this neopolyp. Then we're going to close a snare underneath the band, deliver electrosurgical current to transect the tissue, and that exposes this underlying blue-stained submucosa. Now, to expand the resection, we'll inject some additional fluid adjacent to our prior resection site. And then we'll overlap the prior resection site with additional target tissue, suction the target. We'll deploy the rubber band again. And then again, we've created this neopolyp or pseudopolyp. And then we're going to maneuver the snare around the polyp, cinch it underneath the rubber band. We'll deliver additional current and extend the resection. And once you've done that enough times, you end up with this sort of really long segment, wide field, 50% circumferential resection that's addressed all the Barrett's with no evidence of bleeding or perforation at the base. We generally limit these resections to about 50 or 60% because if you go way beyond that, the risk of stricture increases significantly. But this patient goes home from recovery 1 hour later, has a little bit of a modified diet, but is back to their normal routine the next day. So back to work, back to the golf course the very next day. So this is sort of a dramatic change from what would have been expected just 5 or 6 years ago with transhiatal esophagectomy. Now for high-grade dysplasia, which technically does not penetrate the basement membrane, EMR is considered curative. But for mucosal cancer, we always have to worry about the possibility of regional lymph nodes. And that's why an operation is at least theoretically more oncologically complete, because not only does it address the primary lesion, but it also removes many of the surrounding lymph nodes. We now know, though, on the basis of fairly robust observational data, that if the cancer is limited to the lamina propria layer, if the deep margin is negative, if the tumor is well or moderately well differentiated, and if there's no angiolymphatic invasion on the specimen, then the risk of nodal micrometastasis is in the range of 1 to 2%, probably closer to 1%. And that 1% risk of micrometastasis has to be weighed against the morbidity and the mortality of the operation, the long recovery period, and the consideration that a complete lymphadenectomy is not performed at the time of an esophagectomy. Now, if a cancer doesn't meet these criteria, then obviously the risk of nodal metastasis is higher, and a surgery is, of course, appropriate. But in highly selected patients with low-risk intramucosal cancers, EMR basically has completely supplanted, at least in routine clinical practice, has supplanted surgery in most academic medical centers. And eventually you want to end up with the EMR, you want to end up with this, this sort of wide field, 50% circumferential resection that addresses all visible Barrett's and all visible nodularity. So another technology that sort of exploded onto the scene for the treatment of complicated Barrett's esophagus is radiofrequency ablation, or RFA. RFA is most appropriate for the treatment of flat, non-dysplastic Barrett's that's complicated by high-grade dysplasia. An advantage of RFA is that you can cover so much more ground in one session compared to EMR. And often RFA is used to eradicate any residual non-dysplastic Barrett's after we've done an EMR of the high-grade dysplasia of the cancer. Based on high-quality randomized controlled trial data, RFA appears to be associated with a greater than 80% remission rate for high-grade dysplasia, and that effect appears to be over 75% durable through 3 years. And the rate of serious complications is actually extremely low, even lower than EMR, which also has a very low complication rate. So this is the Halo 90 RFA probe that's been mounted to a tip of a standard gastroscope. After we made, so the treatment surface is actually on the other side of this device. And after we've made aggressive contact with the mucosa, it's going to deliver bipolar thermal energy down to a depth of about 1,000 microns to in essence ablate the mucosal layer. We can overlap ablations to basically end up treating a very broad area. And you can see that this tissue here has been ablated because there's this sort of whitish coagulum of just dead necrotic tissue on top of it. And with RFA, you can actually treat long segments circumferentially with a very reasonable stricture rate. So endoscopic eradication therapy for complicated Barrett's esophagus is associated with an 85 to 95% long-term success rate. Recurrences are infrequent, but when they occur, they tend to occur locally, and they're often amenable to endoscopic retreatment. The perforation rate is way less than 1%, and as I'll show you later, we can often manage these endoscopically. The bleeding rate is in the range of 1 to 4%, and the stricture rate is variable depending on the aggressiveness of your approach. But bleeding and stricture can almost invariably be managed endoscopically. So endotherapy is guideline recommended now for high-grade dysplasia and is expert recommended for T1A cancer. And this represents a major paradigm shift from just 6 or 7 years ago when surgery was the unequivocal gold standard. So we'll switch gears again and discuss the endoscopic mucosal resection of complex colon polyps. So we've known for some time, based on observational data, that colonic polypectomy reduces the incidence and the mortality of colon cancer. But traditionally, polypectomy had been reserved for smaller lesions that are more polypoid, that are easier to grasp with a snare. The larger or flatter lesions that we call laterally spreading were usually relegated to surgery. But now in the last 5 to 7 years, we have an increasing experience with what's known as wide field EMR, and now we know that it's safe and effective, and it's associated with technical success rates in excess of 90%. And if you look at all comers who are referred for these polyps, surgery can be avoided in over 85% of them. And the complication rates are the reported complication rates are at least very reasonable, and they compare very favorably to the reported rates of surgical colonic resection. So the band EMR technique that I showed you in the esophagus is actually not appropriate or safe in the colon because the colon wall is very thin and it's not anchored in most places. So when you suction the colon wall into the banding cap and deploy the band, you end up capturing the whole thickness of the wall. And so when you transect, that results in a perforation. So instead in the colon, we rely much more heavily on submucosal injection. We usually inject a combination of saline and a blue dye, although we can inject colloidal solutions like hydroxyethyl starch and methylcellulose. The purpose of the injection is basically to create a polypoid lesion that's amenable to grasping with a snare, and also to separate the target tissue from the deep muscle layer of the colon wall, so providing a safety cushion. And for these large lesions, we tend to resect them in pieces, so it's called a piecemeal resection until you have complete eradication of the lesion. So this is a complex polyp, or a defiant polyp, that was referred to one of our surgeons and subsequently re-referred to me for endoscopic resection. This was referred by a gastroenterologist because it's in a mechanically difficult position. It's quite flat and large. So we're starting the resection by injecting a combination of methylene blue and hydroxyethyl starch into the submucosal space. Again, the purpose of the injection is to create a polypoid lesion that we can grasp with a snare, but also to separate the target tissue from the deep wall of the colon, improving the safety of this procedure. And then once we're happy with our lift, with our submucosal lift, which we've completed right there, we're going to maneuver a snare around this entire polyp, and then we're going to close the snare, hoping to capture a 1 to 2 millimeter rim of normal tissue around the adenoma. Once the snare is closed tightly, then current will be delivered to resect the polyp. And you'll notice we left a little bit of adenoma at the periphery, which we're going to resect separately. And then it's been my practice, although not fully evidence-based, to close these resection sites using endoscopically deployed clips in order to try to reduce the risk of delayed hemorrhage, which is one of the main complications of this procedure. We can also resect very large colon polyps, often saving the patient a hemicolectomy. So this is a giant, bulky, and laterally spreading adenoma in the patient's hepatic flexure. So this one is so large that we really can't even identify a base to inject. And so what we're going to do is we're going to start by debulking it, which is to remove large portions of the polyp away from the colon wall. Eventually, as we work on this, we'll get to the point where we can inject it, and then we can eventually perform the typical lift, sort of inject and snare polypectomy, which we're completing right here. And after that's done, we need to thoroughly inspect the base of this polypectomy site to exclude the absence of any residual adenoma. And you can see a bunch of scar tissue here, but there actually is a little bit of residual adenoma right there that we can remove with this biopsy forceps. So the last resection technique I'll discuss is something called endoscopic submucosal dissection, or ESD, which has been a total game changer in the management of early gastric cancer in high incidence countries. So this is endoscopic footage of an ESD in the esophagus. So the endoscopist is going to demarcate the target site using these sort of short bursts of electrosurgical current so he can remain oriented during the case. Once that's fully demarcated, he's going to inject a combination of saline and methylene blue into the submucosa underlying the target tissue, so that creates a working space for dissection within the submucosal plane. Then he's going to use that same needle knife device to create an incision in the mucosa. That's called a mucosotomy. And then that mucosal incision is going to be extended to fully expose the submucosa. So once the submucosa is exposed, then it's going to be further injected to create sort of a more robust working space and a plane for dissection. And so using this modified needle knife device, then the submucosa is going to be dissected, essentially freeing the target tissue, which is this mucosal layer, from the deep muscle layer of the esophagus. And as long as the muscle layer is intact, then no perforation occurs. This process is going to be repeated initially longitudinally, and then it'll be extended circumferentially until the entire specimen should be resected in one piece. And this is what's called an en-bloc resection. And it's this en-bloc resection that's thought to make ESD potentially oncologically superior in terms of recurrence rate. although that benefit has to be weighed against many more complication or a higher complication rate and more prolonged procedure times. And since the incidence of gastric cancer, early gastric cancer in the United States is actually quite low, it's not clear yet what role this procedure will play in this country, but perhaps its primary target will be to carve out subepithelial tumors from within the wall of the GI tract, things like GI stromal tumors and carcinoids, lesions that we spend a lot of time, money, and effort following and surveilling currently. So now let's discuss interventional EUS, which is the second game-changing area in my opinion. So endoscopic ultrasound is the presence of an ultrasound probe at the tip of a flexible endoscope. It was originally introduced primarily as a diagnostic modality to assess anatomy and morphology and to stage tumors. But subsequently, EUS-guided fine needle aspiration was developed. So this is a procedure in which we can advance a needle under sonographic guidance into target tissue to acquire diagnostic specimens. And from this technique evolved this whole field of interventional EUS, which has major therapeutic implications. So the quintessential and first interventional EUS procedure was the endoscopic drainage of pancreatic pseudocysts. So as everyone in this room is aware, a pancreatic pseudocyst is an organized collection of pancreatic juice that is a result of either acute or chronic pancreatitis. When these become symptomatic or develop complications like infection, they require drainage. The traditional approach to this had been the surgical cyst gastrostomy or cyst enterostomy. And the aim of that procedure is to create an anastomosis between the cyst and the lumen of the GI tract, allowing the cyst to drain into the lumen and then subsequently collapse and heal. In textbooks at least, the complication rate associated with surgical cyst gastrostomy is in the range of about 20%. That's probably inflated because most of these procedures are now done using minimally invasive techniques, so laparoscopic techniques through the wall of the stomach. But nevertheless, it is an invasive operation. It has a defined complication rate and a defined recovery time. And so in the mid-90s, EUS-guided drainage of these fluid collections was initially introduced and has developed since then. And nowadays, in patients who have cysts that are amenable, so anatomically amenable to drainage, the endoscopic approach, in my opinion, has completely supplanted surgery for simple pseudocysts. So this is an EUS image. This is the probe within the lumen of the stomach. This anechoic area is a 6-centimeter cyst that's in close proximity to the stomach wall. Under EUS guidance, we can advance a needle through the wall of the stomach into the cyst. This is a fluoroscopic view or a real-time image of that real-time X-ray image of that EUS scope. Here's the EUS probe. This is a needle that's been punctured into the cyst cavity. Through the needle, a wire can be advanced and subsequently coiled within the cyst. And then over that wire, the tract between the stomach and the cyst can be expanded using this biliary dilating balloon. You can actually see a waist here in the balloon as it expands across the stomach wall. What this might look like endoscopically is this. This is actually the lumen of the duodenum, so this is a cyst duodenostomy, not a cyst gastrostomy. But using EUS guidance, we've already established a tract to the cyst, and now we're going to expand that tract using this biliary dilating balloon. So once we position the balloon across the wall, we're going to dilate it to its maximal diameter. We'll leave it up for some time, and then once we deflate the balloon, we're going to see this sort of copious flow of purulent pseudocyst fluid into the lumen of the duodenum, and then that tract can be maintained by placing several stents across it to provide durable drainage. The stents we traditionally placed were these plastic stents that you can see right here. These are double pigtail plastic stents with one pigtail in the lumen of the cyst, another pigtail in the lumen of the stomach, and the pigtails prevent it theoretically from migrating. As you can see here, I've advanced a wire alongside the existing stent in order to place a second stent, which is thought to reduce the risk of stent occlusion and improve the clinical outcome. This is an endoscopic view of the intragastric pigtail. So here's one pigtail. So on the other side of this wall would be the cyst. Here's another pigtail. More recently, many of us have switched to using fully covered self-expanding metal stents to place across the cyst gastrostomy tract. These stents are easier and more efficient to place, so they cut down on procedure time, and their lumen is of larger caliber, so they're less likely, they're up to 10 millimeters in caliber, so they're less likely to become occluded by cyst content. The next step in this evolution is these recently approved what are called lumen approximating stents. So this stent has these two large flanges on either side of a saddle, so that anchors in really well. and is thought to be less likely to migrate. Not only that, but this stent has a larger lumen in the range of 15 or 20 millimeters that allows easy drainage and perhaps even access into the cyst with a scope. But I think the biggest advantage of this new device is that it comes with a one-stop platform for basically simultaneous access to the cyst, establishment of the tract, and basically instantaneous deployment of the stent. So this is an example of that. This is a large pancreatic pseudocyst. If you look right here, you're going to see under sonographic guidance the device, this access device, and so they're going to access the cyst. The device itself creates a tract, and here there'll be basically instantaneous deployment of that intracystic flange, which you've seen right here. And if you direct your attention to the endoscopic view down here, you'll see that the endoscopist is going to back away a little bit, establishing a little bit more of a working space. And once they've done that, then they can deploy the intragastric flange. And then you'll see sort of flow of cyst fluid into the lumen of the stomach. Now, if you notice, this video has been running in real time. So this was actually like a 26-second cyst gastrostomy, which is completely mind-boggling. And this is a good example of a really tremendous sustaining innovation within an area that has been a disruptive innovation. So endoscopic pseudocyst drainage is associated with a greater than 90% technical success rate. The clinical success rate, that is the collapse and healing of the cyst, is in the range of 80 to 85%, and that needs to be weighed against about a 10% complication rate. But for cyst gastrostomy, complications are generally pretty mild and can be addressed either endoscopically or conservatively for the most part. Observational data in a recent randomized controlled trial have demonstrated that endoscopic and surgical drainage are clinically equivalent, but the endoscopic approach is associated with lower costs and a shorter hospital length of stay, although we do this procedure all the time in the outpatient setting, and so in many cases there is no hospitalization whatsoever. The harder clinical problem is what's known as walled-off pancreatic necrosis. So instead of just fluid, these cysts contain thick necrotic debris that prevent the cysts from collapsing and healing, and not only that, have a tendency to occlude any transmural stents. And so the treatment for pancreatic necrosis is what's known as an endoscopic necrosectomy, but we literally have to actually debride the necrosis and get it out of the cyst cavity. So this is a case of walled-off necrosis right here that occurred a few months after a bad case of gallstone pancreatitis. This patient's a very poor surgical candidate. Under EUS guidance, we're advancing this FNA needle into the cyst cavity. Through the needle, we'll advance and coil a wire within the cyst right here. Then initially over the wire and then eventually alongside the wire, we're going to do a large volume dilation of the tract between the stomach and the cyst cavity. And as we deflate the balloon, we get sort of copious flow of pus from within the cyst into the stomach, and this is a very satisfying sight no matter what field of medicine you're in, I think. After we've fully dilated that tract, we're literally going to introduce a scope through the tract into the cyst cavity, and now we're working fully extraluminally, and we encounter all this thick necrotic debris. And then using a multitude of instruments, we're going to physically, mechanically debride that necrosis. And this is what's called a two-pronged grasper, but we're basically going to grasp tissue from the necroma, and we're going to physically remove it. And then we're going to bring it through the tract and then deposit it in the stomach for subsequent absorption. And well, I was going to say, so our tools for doing this are not fully evolved yet, and so this ends up being a very sort of time and effort intensive process that requires many hours over multiple sessions, but eventually you can get enough of that necrosis out to allow the cyst to collapse. Because it takes so many sessions, we often place these double pigtail stents across the tract to maintain patency and to facilitate access the next time around. But in this case, after I think 4 sessions, you can see that the walled-off necrosis cavity is fully resolved, and then we can just remove the stents endoscopically. This is that lumen approximating stent that I showed you earlier. In this case, it's been deployed. This is the intragastric flange. You can see pseudocyst fluid draining through it. What you can actually do with these cysts is you can use with these stents is you can use a large volume dilating balloon. You can see the outline of that here, and you can expand that balloon across the saddle or within the saddle of the stent to basically maximally expand the lumen to 15 millimeters. then we can subsequently advance the scope directly through the lumen of the stent into the cyst cavity where we identify this necrosis. And so if this proves to be a stable platform, then it's possible that this stent is going to be able to really sort of streamline our ability to do these complex procedures. So the worldwide experience with endoscopic necrosectomy has been increasing substantially of late. The technical and clinical success rates are thought to be in the range of 70 to 90% or so. Now, this is a more dangerous procedure than cystgastrostomy with a complication rate in the range of 10 to 25%, and the complications tend to be a little bit more serious, including a very, very small but real risk of fatal air embolism. But nevertheless, in many cases, the surgical approach is going to be even more risky, especially in a suboptimal surgical candidate. And in fact, there was a small randomized trial published in JAMA a couple years ago that showed that endoscopic necrosectomy was superior to surgical necrosectomy in terms of inducing an inflammatory response and in terms of a composite clinical endpoint that included major complications and death. So as you can probably tell, endoscopic necrosectomy is technically very challenging. It's not widely available, although we have several people at this institution that do it. It's very resource, cost, and time intensive. And as we mentioned, it's quite dangerous. So it certainly has not supplanted surgery for walled-off necrosis, but it's a major factor in a multidisciplinary decision, and it's a major factor in an armamentarium for a patient population that has relatively limited options. So EUS-guided access and drainage of the bile duct and the pancreatic duct is in its infancy, but it does seem to represent a viable option for patients in whom standard techniques are not feasible. So this is a case of an EUS-guided choledochoduodenostomy, so establishing a tract between the lumen of the duodenum and the bile duct to palliate malignant obstruction from a pancreatic head cancer. Normally we do an ERCP to palliate this obstruction, but in this case an ERCP was not successful because of tumor invasion and involvement of the duodenum and the papilla. And so this is EUS footage. You can see here a dilated bile duct. This is the portal vein. Under EUS guidance, we're going to advance this needle into the duct, and then we'll inject dye through that needle to opacify a typical cholangiogram. Then through the needle we can advance this wire into the left hepatic duct, and then over a wire using the same needle knife device we can establish a tract between the lumen of the duodenum and the common hepatic duct. And so the wire will direct us in the direction of the duct, and then we will, as we approach the wall, we'll start to deliver electrical current. And you can actually see the exact moment at which we puncture through into the duct because we start getting drainage of bile. But once that tract is initially established, then it should be expanded. And we're doing that using this 4 millimeter biliary dilating balloon. This is very close to a standard angioplasty balloon almost. And so you'll see here the balloon fully inflate. And once we've inflated the balloon and established that tract, or expanded that tract, then we're going to position one of these fully covered self-expanding metal stents across the tract. This is the stent deployment catheter. And so we'll advance that across the tract, and once it's in good position and we're happy with the position, we can start deploying the stent. You can see here that the stent is partially deployed, and then we'll complete the deployment. And once we do that, there's always a moment of tension until we can get this gush of bile that confirms to us that we're in the right place and not sort of in the subhepatic space or elsewhere. So this is a case of recurrent pancreatitis and a dilated pancreatic duct that you can see here after surgical resection of a neuroendocrine tumor from a patient's papilla. So we suspect a stricture at the pancreatic orifice. But because of all this distortion and edema, I wasn't physically able to find the pancreatic orifice to do an ERCP. So we're going to do what's known as an EUS-guided rendezvous procedure to facilitate access to the pancreatic duct. This is EUS footage. This is the pancreatic duct. This is the splenic vein. Under Doppler guidance, we're going to advance the needle into the pancreatic duct. Through the needle, we'll inject contrast, and that'll opacify a typical pancreatogram here. Then through the needle we can advance a wire through the pancreatic duct, through the papilla, into the duodenum. And so when we swap out from an EUS scope back to the ERCP scope, the wire's emerging directly through the pancreatic orifice, and it's very easy to identify. And we can use standard ERCP techniques to cannulate alongside that wire and achieve access into the pancreatic duct. And so this, if you haven't done ERCP, this is extremely distorted and very difficult to identify. So this is the rendezvous wire that's coiled in the duodenum. This is an ERSP scope, and this is a typical catheter that we've used to access the duct and place this pancreatic stent to solve the patient's problem. So this is a similar type case. This is a patient with recurrent pancreatitis and abdominal pain after a Whipple resection where they removed the pancreatic head. We suspect a stricture at the pancreatico-jejunal anastomosis, so where they sewed the pancreatic duct to the jejunum. And the goal is to try to place a stent across there to alleviate the patient's symptoms. But despite extensive efforts, I'm not able to identify that pancreatic orifice, presumably because it's extremely stenosed. And so what we're going to do here is also attempt an EUS-guided rendezvous procedure to facilitate pancreatic access. And you can see here, this is a fluoroscopic image of the EUS scope. If you notice, there's a needle that's actually punctured the pancreatic duct. And we've clearly injected contrast because you can see a pancreatogram. But because of this very tight angle, I was not able to flip a wire in the direction of the jejunum, in order to get through the pancreatic orifice. So what we did instead is we injected a bunch of methylene blue dye into the pancreatic duct. And then we'll remove the EUS scope and go back down with the standard endoscope. And we see this sort of slightly blue-stained divot. And as we suction, it becomes clearer and clearer that some methylene blue is actually coming through, indicating that that's indeed the pancreatic orifice. And then under direct visualization, we can advance a wire through that orifice into the pancreatic duct. The problem in this case is that anastomosis was so tight and so fibrotic that I was not able to follow the wire with any standard instruments. So this is a conventional ERSP sphincter tome, and clearly I can't get it to go through that orifice. I'm actually going to then swap out to a more tapered instrument to try to gain access. And even that is not successful just because this anastomosis is so stenotic and fibrotic. And so what we'll then do is we'll switch to something called a Sohendra stent extractor, which we'll use to literally drill our way through that orifice into the pancreatic duct. And so once we've roto-rooted our way in, then we have sort of easy access to dilate that tract further and then place a stent. So the last area I'll discuss is the endoscopic closure of GI luminal defects, both acute perforations and chronic fistulas, and I do think this is basically a direct offshoot of the NOTES experience. So this is a device known as the bear claw clip. It's this large caliber clip that's been mounted on a clear cap which can be attached to the tip of the scope. The target tissue, including the perforation, can be grasped and or suctioned into the clear cap. The clip is then deployed distally, and it's going to capture everything that had been within the cap, including the perforation. So this is a case of that bear claw in action. This is a esophageal EMR like I showed you previously. Here we're closing the snare underneath the band. We're delivering electrosurgical current, but it's taking forever to transect, and that's usually a bad sign. That indicates that there's muscle in there. And as we inspect the resection site, it doesn't look quite right. It looks like there could be a defect in the esophageal wall. And as that resection site continues to expand, it first becomes fairly clear and then abundantly clear that there's a hole in the esophagus, right? And so the bear claw has already been mounted. The perforation is going to be lined up and then suctioned into the cap, and the clip is going to be deployed. And you can see here that this is the entire perforation up here. It's been completely and robustly captured within the prongs of this clip. This patient remained asymptomatic. He had a negative esophagram and was fed and discharged uneventfully the next morning. And this represents a major, major change from what would have happened even 2 or 3 years ago, where the patient would have required a chest operation to close the primary perforation, as well as to potentially drain the mediastinum. This is another case. This is not what you want to see during a screening colonoscopy. This is edge of the liver, and that's diaphragm. This is a gallbladder and some peritoneal fat. This was a sigmoid perforation that occurred during a screening colonoscopy at an ambulatory surgical center. The endoscopist called me urgently, and the patient was transferred to our therapeutic endoscopy unit via ambulance with the intent of providing primary endoscopic closure. So instead of rushing the patient to the hospital for an operation, he was rushed to the hospital for an endoscopic procedure. Again, a major paradigm shift. So here we're exploring the sigmoid colon with a standard gastroscope, with a therapeutic gastroscope. We identify the perforation right there. I just exited through it. This is peritoneal fat. Within a couple of minutes, we can mount the clip and we can re-identify the perforation. But in this case, as I try to suction the perf into the cap, all I'm getting is all this peritoneal fat. And so I'm a little worried that if I deploy the clip, I'm not actually going to capture the perforation. So we're going to use this grasping device to draw one edge of the perforation into the clear cap and sort of stabilize that perforation. Then we'll augment that mechanical traction with suction, and then it becomes clear that we have all 360 degrees of the perf as well as a little bit of fat within the clear cap. And this is the clip here. You'll see it released in a second. There it goes. And then it becomes very clear that we've captured the entire perforation robustly within this cap. This patient underwent a hypache enema a couple hours later. The clip is right there, and you see zero extravasation and contrast. She actually had a lot of abdominal pain because of all this pneumoperitoneum and capnoperitoneum, but within a day or so, her symptoms were much better, and she was discharged uneventfully the next day. Believe it or not, she actually came back for a screening colonoscopy 4 months later. And this is a perforation fully healed, still captured within the jaws of the clip. And so it's not just the availability of the device, which is huge, but it's also that understanding that not all perforations require surgery and that the majority can be addressed endoscopically. We're also much better at treating chronic fistulas. So this is a non-healing gastrostomy or peg tube site that's leaking externally. So perforations want to heal. That's their natural tendency. All you have to do is approximate the tissue. Fistulas, on the other hand, are epithelialized. And epithelium naturally doesn't heal to other epithelium. That's why your tongue doesn't heal to your cheek. That's why your GI tract doesn't heal to itself. And so to treat a fistula, we really have to ablate and destroy that epithelium, hoping to induce an inflammatory response that will allow healing. And that's exactly what we're doing here. We're using this technology called argon plasma coagulation to ablate and essentially destroy the epithelial lining. Once we're happy with that ablation, we can mount the bear claw and we'll approach the fistula opening. We're going to use this grasping device to grasp sort of the tunnel of the fistula and pull it into the cap. Initially we're using mechanical traction, and then we're going to augment that with robust suction. And here's the fistula opening and part of the fistula within the cap, and then we'll deploy the clip. We've done this in the stomach, the esophagus, the small bowel, and the colon. Our success rates are not great, but in the range of 50%. But if it works, it saves the patient a major operation. The last thing I'll discuss before concluding is another device available on the market for endoscopic closure. This is a novel flexible endoscopic suturing platform that was developed in part at MUSC. This device works because there's a needle and a suture that can be toggled back and forth between this needle driver and this contralateral jaw. It also has a corkscrew grasping device that will grasp tissue and pull it into the trajectory of the needle. The needle and suture are then driven through the tissue, and the tissue can be released. The needle will be toggled back onto the needle driver. The contralateral side of the defect can then be grasped. And then that will be brought also into the trajectory of the needle driver. And then that will be released. The needle will then again be toggled back to the needle driver. I promise I'm not going to go through the whole sequence. But then you do that sequentially and you end up with a nice running stitch. The needle itself is then fully released and it serves as a T-anchor. The suture can then be pulled tight to approximate the edges. Then once the suture is pulled tight, it can be simultaneously cut and trapped within the cinching device, providing complete closure. This is a case of a gastrogastric fistula after Roux-en-Y gastric bypass. It was referred for endoscopic suturing. You can see that the fistula tract has already been ablated using argon plasma coagulation. This is the needle driver side. This is a contralateral jaw. So what we're going to do is use the corkscrew device to grasp the tissue. And then we'll draw that into the trajectory of the needle driver. It's somewhat hard to tell, but the needle just got driven through there. It ended up on the other side. The process is going to be repeated along the contralateral wall. And then you see that we have sutures on both sides. We're going to continue that process until we have a running stitch. And here I'm just practicing closing the running stitch just to see if it does result in tissue approximation. You can tell that it is providing closure. And then once we're happy with that, we're going to pull the suture very, very tight, and then we'll simultaneously cut it and trap it, and that that'll provide complete closure of this previously wide open defect. So in summary, since I entered GI in 2005, I think we've seen some really major advances, both sustaining and disruptive. I think that has led to fundamental changes in how we treat GI neoplasms, how we drain pancreatic fluid collections, how we can access the pancreatic and bile ducts, and how we close acute and chronic luminal defects. I think with sound procedural technique, with thoughtful and responsible patient selection, with a commitment to aggressively manage complications, we've really seen some very favorable outcomes, and we've dramatically improved the risk-benefit ratio of treating many of these conditions. And I think the next step in our evolution is to establish an evidence base through randomized trials. But I think if the last 10 years have been any sort of indicator, I think the sky's the limit for therapeutic GI endoscopy. So thank you very much.